So we're talking about GTN, and so you have to understand that in pregnancy, beta HCG is produced, and there is an implantation which happens, and sometimes the implantations go deeper, and you have cytotrophoblast and syncytotrophoblast and deciduous bacillus, which is derived from the endometrium and the placenta. It's in between the endometrium and the fetus. In there, you have the syncytotrophoblast, which produces beta HCG, and the cytotrophoblast, which produces the cells. Now, HCG as alpha and beta subunits, and HPL is something else. The beta and alpha and beta subunit of HCG goes to the ovary, corpus luteum, progesterone supports the first week of pregnancy is supported by progesterone, and then after that, beta HCG takes over from the syncytotrophoblast. Um, Now, the thing is that HCG in early pregnancy is is pretty high. And it doubles every 48 hours in early weeks, and it peaks at 10 weeks and then starts to decline. By 12 weeks, HCG is around 10 to 50,000 international units, and post pregnancy HCG should fall. And if you follow the HCG graph, you should be able to understand GTN. And if HCG does not fall at the end of pregnancy, you should suspect GTN. Now, there are three types: total free and glycosylated HCG. Glycosylated HCG is a very aggressive HCG, and it is used to detect aggressive trophoblastic neoplasia. Now, we know normal placenta, creta, increta, and paracreta. Paracreta goes through normal, and so basically GTNs are benign and malignant. The benign is a complete and partial mole, and malignant forms trophoblastic site choreo and invasive mole. Complete mole is when you have an empty ovum with a single sperm which undergoes duplication inside, or you have two sperms which are fused to form protein. So it has endometrial script like clusters, cistern, high NCG producing complete mole. And in partial mole is when you have three. Partial is T for three, part is parts. So that's how you remember partial mole will have fetal parts. And you have three, and then so coming to choriocarcinoma. Now, there are two ways to diagnose it, and one is if there is a plateau of HCG and it's not dipping, or HCG continues to rise, or you have histological diagnosis, and we arrive at the diagnosis of choriocarcinoma. We already discussed about HCG levels, and it depends on when you have this abnormal HCG. So if you have it in the first trimester where you have this node, then you should suspect molar pregnancy. But if you detect it post like pregnancy, then it's more concerning for invasive and choriocarcinoma, and that's why the grading has this factor. Now, what are the staging? Stage one is confined to the uterus, stage two outside the uterus, stage three is to the lungs, and stage four is all other metastasis. And now there is a WHO prognostic scoring system for this, and we consider seven factors. Basically seven, like one, two, three, four, five, six, seven, eight factors. Seven is the magic number. Seven single agent, less than seven is single agent. Score greater than seven, we'll need multiple chemo agents such as EMA-EP or EMA-CO. All stage four are considered high risk. Well, now the age, and so there is no three in the score, so it's one, two, and four. And is a score of zero is less than 1,000. Score of one is 1,000 to 10,000. Score of two is 10,000 to 1 lakh, and four is greater than 1 lakh. Now, uh, this 8 is very important because 8 number of 8 into 2 is, you know, 4. And here, you basically, if the 2 8 into 2 drugs is 4. Okay. And um, so basically, you have to find a way to remember this scoring system. There are various mnemonics. You can think of Captain TNM, beta HCG Captain TNM, and C is the prior chemotherapy, and N is the number of mets. So 8, score is less than 8, and 1 to 4. And site of mets, again, 4 is brain and liver, 2 is GI tract, 1 is kidney and spleen, 0 is lung. The largest tumor of 5 into 2, 10, 10,000 to 1 lakh, 7 to 13 months, and here 1 to 4 months, less than 4 months. We look at the beta HCG, and if it's abortion, term, or molar, pregnancy, less than 40, greater than 40. So that's how you would. And if the WHO score is less than 4, it's low risk GTN, and 4 to like 7 is intermediate, and greater than 7 is high risk. If they don't need pregnancy, then you can do hysterectomy. Otherwise, you can continue with that methotrexate and actinomycin. They are single agent chemotherapies. Now, uh, single agent, you can give methotrexate 0.5 milligram per kg. So for 100 kg, for 50 kg, 100 kgs, 50 or 25 milligrams IM daily for 5 days, or you can pulse methotrexate 50 milligrams IM weekly, or you can give actinomycin D if 10 into 100 is 1000 microgram, 1 milligram basically, or 1.25 milligram every 2 weeks. So basically, you mustn't give more than 1000 micrograms per day of actinomycin. You can either give methotrexate daily, actinomycin daily, high dose methotrexate, and folinic acid. So methotrexate and actinomycin D for low risk GTN, and both were equally effective. You can also alternate them both if they don't want further pregnancies. You advise hysterectomy, section curettage, uterine embolization, and oligometastatic resection. Maintenance chemotherapy is continued until HCG values are returned to normal, at least one course. So how many cycles? You keep giving it until the LCG normalizes. Um, you repeat every 14 days until the LCG normalizes. So that's how you manage low risk GTN. And now, when we come to intermediate risk, we will do the same with methotrexate and actinomycin D. If complete response is achieved with alternating methotrexate and actinomycin D, very good. If you don't get complete response, then you should escalate to high risk JTN management, which would use EMA-CO or EMA-EP regimens. Now, high risk is WHO score of greater than 8, and lung is not a high risk feature because we already saw the score is 0. GIT is 2, GUT 2, and the brain is, you know, 4. So high risk lung mets are not high risk per se in GTN, not concerning, and vaginal mets also under hysterectomy. EMA, EMA, and EP, EMA-CO, EMA, Co. So on day 1 and day 2, lamivudine, actinomycin D, actinomycin D, methotrexate, folinic acid, and Co. On day 8, Hemaco and Hema-EP, 70% would have very good response. and EMA-EP is the other protocol, and has proven very good effect in GTN. So that's a quick overview about GTN. There's a lot more, but in 10 minutes, we're going to cover this one.